I would like to thank Seong Ho and the team for the invitation. And it always a pleasure for me to contribute my small part for this meeting. And this slide basically the courtesy of my fellow Dr. Naomi. So I am presenting a case of a 3-year-old boy with underlying DiGeorge syndrome and tetralogy of Fallot with pulmonary atresia. So he had the surgical repair, a study operation about a year ago in the other hospital, and he was previously well, pink, and on regular follow-up with the latest consult about 6 weeks prior to the presentation. Right, so he presented with a sudden onset of cyanosis in the referring hospital and was brought into the hospital immediately by the parents. And he had history of upper respiratory tract infection and also fever 3 days prior to the presentation. And the patient was initially on aspirin, but was stopped by the mother about a month prior to the presentation. All right, so on physical examination, he was cyanosed. The saturation was only 40% under room air and 75% on the BiPAP. He was tachycardic and hypertensive, basically in shock. And there was also raised jugular venous pressure, poor pulse volume, and also prolonged capillary refill time. There was a normal vesicular breath sound, and also liver was palpable about 3 centimeters below the subcostal margin. So a few minutes later, he arrested and required a CPR for about 3 minutes. So he was ventilated, required a fluid resuscitation, and was started on inotropic support, noradrenaline, and adrenaline infusion. And the bedside echo showed a depressed RV function with pulmonary artery thrombus at the bifurcation. So in the referring hospital, he was started on heparin infusion. So despite intubation, ventilation, the highest saturation can be achieved is only 85% with FiO2 of 90%. So the atrial blood gas also showed worsening metabolic acidosis despite adequate volume resuscitation. Hence, he was referred to our center for further management. So on arrival to our center, he was ventilated with high setting ventilation. FiO2 was 95%. He had labile saturation, about 60 to 90%, with PO2 ranging 40 to 50. He was tachycardic, heart rate was 130 beats per minute, and persistent labile haemodynamic hypotensive with escalation to 3 inotropic support. All right, so the echo showed impaired RV function, basically biventricular function, especially the RV, and there is no obvious clots in the RV cavity. And on the right-hand panel, you can see there is actually a clot at the bifurcations of the pulmonary artery extended from the RPA into the LPA. So we proceed with urgent CT angiography, and you can see that it shows almost filling defect in the right pulmonary artery extended slightly into the left pulmonary artery. Distal branches of the pulmonary arteries were delineated very well. So this is suggestive of no distal thrombosis. And the tissue density was also suggestive of acute thrombosis. So in summary, this is a 3-year-old boy with acute pulmonary thrombus at bifurcation area of pulmonary artery and depressed biventricular function, and hemodynamically was unstable and hypoxic despite high inotropic support and high ventilator settings. So we were contemplating what is the best option for this boy. So what are the pros and the cons? And basically, we need to decide what is the best for this patient at the moment. So there are three options. The first one is a medical treatment, means systemic IV anticoagulation, like heparinization as started in the previous center. And this is probably the least invasive treatment, is easily available, and also, but again, it's a risk of systemic bleeding, and the thrombus might not be fully resolved. So the second option is basically surgical embolectomy, and this is probably the definitive treatment for this patient. However, in the very unstable patient, post CPR, and probably not the best option at that time. And it carries also high morbidity and even probably mortality. And he may require ventricular support like ECMO after the surgery. So another option is basically, the third option is a catheter-based thrombolysis, and probably this is carry less morbidity or mortality, and however, the thrombus might not be fully resolved. Hence, we decided for the third option, and this is considering all the factors that we have discussed. So we brought the boy to the catheter lab. So the intended procedure basically to perform percutaneous catheter-directed thrombolysis using acoustic endovascular system. And we were wearing full PPEs basically, because this is considering it might be COVID infection complicated with acute thrombus. And the initial angiogram showed white pattern conduit, and flow into both branch PA was still seen clearly. And on the directed angiogram, it showed thrombus on the proximal part of the RPA, very little flow into the RPA. However, this patient arrested during the procedure before we could do anything. So hence, from there, we decided to place what we call a fountain catheter in the close proximity of the clot into the right pulmonary artery. And the recombinant tissue plasminogen activator, the RTPA, 10 place, was infused through this catheter at 50 ml per kilo per hour and continue in the ICU. So we monitor for the overt bleeding and also allergic reaction. So the progress of this patient. Sorry. All right. So a few hours after treatment, he showed some improvement in terms of oxygenation and more stable hemodynamics. And by 12 hours of treatment, we replaced the RTPA to heparin infusion, and the boy showed a significant improvement of the hemodynamics. Hence, at day 3, we remove the catheter and continue the heparin systemic infusion. Despite improving hemodynamics, the echo still showed poor right ventricular function, and the clots was still basically there, and there's some flow acceleration to the both branch pulmonary artery. So at day 4 of after the treatment, we noticed the child had hypoxia and also depressed RV function. But otherwise, the hemodynamically, he was still stable, and inotropic support was able to be tapered down to only single low-dose inotropic support. And finally, we subjected the boy for surgical embolectomy, as he was very stable at that time. So the boy showed improvement of refunction, and also the inotropic support was basically went down. And it was a very remarkable improvement in terms of biventricular function. And echo on the branch PA also showed good flow into the both branch pulmonary artery, and the conduit was widely patterned. So he was discharged 10 days after surgical embolectomy. And we were also wondering why this patient developed acute thrombosis. And hence we sent the thrombophilia screening from the beginning. And his thrombophilia screening showed a significant reduction of antithrombin 3, protein C, and also protein S. And the study was also noticed the lupus study was also negative. But bear in mind, this study was performed when the child was unstable, and it might not reflect the actual condition of the child. So in summary, this is a 3-year-old boy post-Rastali operation with acute thrombosis of pulmonary artery, hemodynamically improved after catheter-directed thrombolysis treatment, and successfully underwent a surgical embolectomy. So in conclusion, the indication of platelet therapy for post-RVPA conduit placement, example like a Rastali operation, is still a bit controversial. It's center-based guidelines. And the catheter-directed thrombolysis, the CDT, is a safe procedure and lower the risk of bleeding and also other complications. It also dissolves clots without damaging vessels, valve, or the heart walls. And surgical embolectomy in a stable patient result with good outcome, and ventricular support post-surgery, example like ECMO, should be considered in unstable patient. So point for discussion is probably the management of acute pulmonary embolism in hemodynamically unstable patient, medical therapy compared to catheter-directed thrombolysis and surgery, and what management basically can be initiated at the peripheral center before transferring to the specialized unit. Is it adequate just for stabilization of the airway and also circulation, or heparinization was also indicated at that time? And what timelines are we looking at the best favorable outcome? And also role of aspirin or any other anticoagulation therapy in prevention of a thromboembolic episode. So with that, I thank you.